So I'm about to meet the surgeon who, if I am sort of able to have the surgery, would be doing the operation. And I believe that she specialises in dystonia, so that's really encouraging. And I'm just hoping that she's going to be able to share a plan with me if that's what they feel is the best course of action. But yeah, I'm just finding my body's going bananas at the moment, which is a sort of sure sign that I'm feeling anxious. So I'm pretty certain you'll be very curious about what's on my list, whether or not I'm going to be suitable for the surgery, and is there a date, how long the surgery takes in itself, you know, will they do the head and the chest separately or together, how long will I be in hospital, is there any special prep, what on earth should I do with my hair? Am I going to end up with a weird mullet in the surgery, or do I cut all my hair off in advance to make it easier for them to be able to do what they need to do? And then in terms of the programming, I know that there would be a plan for, well, and again, what device I would be having. You know, there's different companies provide the technology for the kit that they use, so what the differences are in that. There's all sorts really, but essentially none of it makes any sense unless I'm actually able to have the operation, so that's the main thing. Obviously I don't have the results of my genetic test, so I need to talk to her about that and whether or not that's something that she feels would be a deal breaker. I'm hoping that that isn't the case, but again, I just have to wait and see.
So in terms of the DBS journey, you've seen various people, you know, you had your L-DOPA test and things. What's happened in that sense? What are your feelings about having DBS?
It's a big deal for me to let somebody, I suppose like most health professionals, we're sort of quite good at being on the delivery end and not so good at being on the receiving end.
Absolutely.
I was thinking this could be something that maybe would give me some relief, and so I was kind of on board with it, definitely. I know it's not going to cure Parkinson's. I know that it's only likely to have an impact on some of the motor symptoms, but those are the things that slow me down. Those are the things that stop me from, and that actually make me probably more tired, because, you know, when spending all the day with everything being switched on is exhausting.
Well, kind of looking at you there, the dystonic side of it seems much more of an issue than the tremor side from what I see just now. And looking at the position of your hand, there are different options of how you do DBS and Parkinson's, basically where you bounce in the brain, you put the electrodes. And when someone has very dystonia dominant Parkinson's, that would steer you towards a different target than perhaps someone who had more sort of tremor dominant, more rigidity dominant. That of itself, really, the GBA mutation is actually quite important, because the relevance of that is probably more of an issue in someone where you were going to use what's called the STN. Is that something you've heard of? Rather than the GPI, which is what we would use generally speaking if someone's very dystonia tolerant.
The only thing that was outstanding was this genetic test that I was...
So GBA they've sent off. There's been a bit of discussion about what the role of testing for GBA is at the moment and how much it should influence whether we go ahead or not. There is some evidence that people who have the GBA mutation, that their disease progression is a little different and possibly a little more rapid. But there's an awful lot of holes in our knowledge about its relevance as well. And this has been discussed in great depth at our MDT with myself and Prof. Pavesi and the other members of the team. I have a very surgical take on this, which is that if it's there and we can't change it. And what I see in front of me is someone whose Parkinson's is not well enough controlled to give them quality of life, and where a DBS could potentially help them. So it wouldn't be something where I would think that should not make us go ahead. Clearly, in the end, it's you that decides whether you have surgery, and if this is something that would worry you and that you wanted to wait for, I would respect that completely. But personally, I wouldn't feel that that was something that I would necessarily wait for.
There's something like only 3% of the population that potentially who have this particular gene sort of pattern, and that, as you say, it's not necessarily that it would make me get worse, it's just I might not be as well as somebody who didn't have that mutation. So I've watched my Parkinson's really escalate over the past couple of years. And even if I can just reduce my pain a little, it would be worth it. I'm all about quality of life. Right here, right now, if you offered me DBS, I would basically sort of be delighted, and I would be really happy to go ahead. Yeah, I would be very happy. I would feel privileged to be able to have the therapy, and it's just a matter of now whether or not you feel the genetic test needs to come back for that particular site.
I don't think it makes a difference.
Okay.
I think there are people who would disagree with that, but you know, in the end, I don't know if I'm going to walk home this afternoon and get hit by a bus. You know, there are things about the future that we don't know, and if we did know, we couldn't alter them.
Yeah.
And I think we should deal with what's in front of us rather than what might be. You know, we might have another COVID wave. We might all not be here in a year. Who knows?
Yeah.
Putin might press a button. Whatever. You know.
I'm assuming that, sort of talking through this, that you think that I might be a suitable candidate to go forward with this, and can I do my happy dance?
If you want a DBS, you can have one, in my opinion.
Perfect.
I think you need a DBS, is what I think.
Yeah.
So we've obviously got your MRI, which is fine. Do you know anyone who's had a DBS, or you've presumably read a bit about what the procedure involves?
I've kind of, I know a little bit. I haven't really focused a lot because I just thought I won't go down the rabbit hole of the internet, because there's so many different experiences, and there are people that have connected with me who've had DBS and who have had a variety of different experiences. So most of the people who have had benefits from it, some of them have also had some changes in speech, or they've had other things that have happened, or their balance is suddenly not quite as good as it was. So there are people who've said actually it's taken them back to where they were 5 years ago. So there's a whole host of different experiences.
So I mean, DBS, as you know, it's not a cure, but what we're trying to do is get better control of the symptoms that you have. It tends to be used along with the medications, not instead of. So we'd not be looking at getting you off the tablets. And of course, you said the on-off thing isn't a major issue for you, because that's often one of the things that DBS is good at, is that evening that out. So, but you know, you've got quite a dystonia dominant pattern of Parkinson's, and a lot of that stiffness and things we should be able to help. And of course, you know that the disease progresses over time, and you know there's no real benefit in waiting for something that you know that you're going to need at some point. And so, having said you don't do things for what might happen in the future, I'm now going to say that DBS does kind of future-proof things a little bit, because it means that you've got it there to respond, and you know, as you need it to, you know, if and when symptoms change. In terms of the operation itself, it takes about half a day. We do it with patients asleep for the whole thing. If you've seen this on telly, a lot of people do people awake with Parkinson's. We don't do it that way here. We've tried various different techniques over the years and audited and looked at what makes a difference, and in the end, we don't find any benefit to testing people intraoperatively, so we don't do that. It involves the world's smallest hair shave, I promise you. It's a tiny amount of hair that has to be taken off, because the electrodes are put in at the top.
Yes.
And there's a little connector that goes in there.
Yeah.
But you've got long hair, and it'll brush over and cover it completely.
All right, amazing, because that's one of my questions. It was like hair.
Tremendously important.
Because I was thinking, did I need to cut my hair first, or but you just will work around. You'll just find.
We'll work around it. The one thing you need to do is to, if you get your hair coloured, is to do it immediately beforehand, because you then can't do it for about 4 or 6 weeks afterwards.
All right, okay.
So that's crucial. Tiny amount of hair shave, but we will be able to cover that because you've got long enough hair to cover it.
Okay, perfect.
So the device is in 3 parts. We've got the electrodes that go in from the top.
Yeah.
We've got an extension lead that runs from a little scar there under the skin to the battery, and then the battery that sits in the chest.
So does the other side go round the back?
No, it comes round the front.
Round the front, okay.
Yeah. It's just a single extension lead for the
so they'll both go down like that and then meet?
No. Electrodes there, and then both of these electrodes the ends of them get moved over to there. So it's a single wire that runs down. And you know, many years ago these wires were quite thick, but the technology's a lot better now, and they're really quite thin. It's now a single wire, it's thin and it's quite stretchy.
Okay.
You can still feel it. If you press under your skin, you'll be able to find it, but it's not visible. The rest of the world would not see that it was there.
And do you do the head and the chest at the same time?
Yes, the whole thing's implanted together.
Wow, that's amazing.
In terms of where the battery goes, this is something for us to negotiate cosmetics, because obviously the lower down in the chest, you know, for example, if you're wearing a dress like you're wearing now, we can put the battery low enough to hide the scar.
Okay.
Again, another female discussion, but the lower it is in the breast, the more mobile the battery is. And sometimes some women find it's a bit of a problem if it's too low down, and they prefer it a bit higher up.
Right, okay.
For that
I don't
reason.
care about scarring. I think it's about where it's going to be safest.
And most comfortable from your perspective. Batteries are rechargeable. In terms of kit, all these things are getting smaller and smaller over time. DBS batteries, it used to be like putting a cigarette case in somebody. It was a horrible thing. Now it's much smaller, but it's not as small as a heart pacemaker.
Okay.
The battery lasts 25 years. It's a rechargeable battery, so you're not looking
Might do me all right.
Well, I hope not. Implanting it, the whole thing takes about 4 hours. It's fiddly, but it's not. It's not a huge thing to do to the body, because most of it's under the surface. Yes. It's only the electrodes that are inside. Most people are in hospital overnight.
Okay.
The main thing is really living with the device, coming backwards and forwards to have it programmed, having to recharge it. It's quite a life change in that sense of having DBS. People cope extraordinarily well with it, but it's just, it is that, once it's there forever. And so there is that sort of commitment side, from both doctor and patient, that we're gonna work with this now. Risks of surgery, very, very, very small. You're young, fit and healthy, and there shouldn't be any problems coming through surgery. But there are risks that are unavoidable. The most important one is by far the rarest, and that's the risk of causing bleeding when you put the electrode in, and that would cause a stroke. It is incredibly uncommon. So, just putting it in context, we're under the 1% mark in this unit for stroke. I've had one patient in 25 years. It's rare. All the other problems that you can get from DBS you can fix if they happen. If a system gets infected, you can either treat it with antibiotics. If the antibiotics get rid of it, that's great, but if not, sometimes you have to take components out, treat an infection, put them back in again. But do you drive?
Yes.
Okay, you need to be off driving for a few weeks after your operation as well. So if that's an issue for you in terms of, getting to and from appointments or whatever, then we might need to think about how we manage that. But it's just temporary. You don't need to, surrender your driving license or anything. It's just that the DVLA says that the current thing is 6 weeks, but they do change it fairly frequently. The other frustrating thing about DBS is it takes time to be effective. Most people find that it takes at least 3 months to begin to see an effect, and sometimes up to a year to get the best possible effect. So it's, it'd be nice to be able to put it in and press go and it would all be fine, but it just requires a bit of patience.
Hey everybody, just thought I'd let you know that I'm through my meeting with the surgeon and everything went really well, and my date is the 30th of August, so yay! Exciting and terrifying all the same, all at the same time. Thanks so much for everybody for your support. Catch you all later. Bye now. I never thought that I'd be excited about having brain surgery, but I am. It feels a bit surreal actually. That it's actually going to happen. But I just feel really relieved. Wow.